Marhaba, our guest today is Dr. Hanan Sheikh Ibrahim. Dr. Hanan is a neurocognitive geriatrician and she is the lead of the Brain Health Clinic in the Neurological Institute at Cleveland Clinic, Abu Dhabi. Dr. Hanan is with us today to talk about pioneering the Women Brain Health Clinic at Cleveland Clinic, Abu Dhabi. Welcome, Dr. Hanan.
Thank you. I appreciate that you're shedding the light on this important topic to my heart and to every woman. So why did we pioneer that? Because we realize that women manifest differently. Actually, women are at the epicenter of Alzheimer's disease. Women get affected by Alzheimer more than men. For every three with Alzheimer, two of them, unfortunately, are women. And we've been in medical community globally doing great job in preventing breast cancer for women health. We did a lot of milestones globally, as well as for osteoporosis and cardiac, but women brain health now is getting more attention because now the research is supporting a different manifestation. Women have structurally different brain, anatomically and hormonally, and even the mechanism gets more complicated in Alzheimer, where you have more interplay of hormonal and other factors. In addition, women have different trajectory of Alzheimer. They can get faster course of deterioration, and their manifestation is different. So also they notice in medical literature, in science and research, that we have been treating women and men in diagnosis and identification through unisex tool. Even in research, we've been using the male model, even though their brain anatomically is different. So we're not going to be expecting the same result here, right? We're going to expect the same result. So they realized that this unisex tool can miss women diagnosis by 3 years. So the woman can have MCI, mild cognitive impairment, and getting missed 3 years. And this have a greater ramification, because if you miss MCI, you're missing the window of opportunity to modify and to prevent and to treat the disease.
Yes, thank you. So we all know that a woman has a menopause phase. Is there anything called menopause brain? And if yes, what does that looks like, or what does that mean?
Actually, menopause used to be thought of like something related to gynecological, endocrinological, ovarian, but menopause goes beyond that. And now the new definition backed by science, it is a neuroendocrinological inflection point. It affects the whole body, and the brain is hit hard in menopause, especially if you have other comorbidity in the patient. So in the patient and in women who is healthy. So menopause brain comes from estrogen withdrawal. Estrogen in physiological status has a great role in enhancing cognitive reserve in women, in neuroplasticity, and also a neurotransmitter enhancement, including cholinergic reserve, including other neurotransmitters in charge of sleep or and anxiety and mood, and all psychological, mental, and cognitive. So when women go through menopause, estrogen withdrawal, it is normal to have some of those symptoms related to those, like disorder of those neurotransmitter, and some women get hit hard by that. And that's opposite to what we used to think when we were med student. Mostly we were told this is an anxiety and menopause stress, it's all in your head, and patient go to the doctor and get ignored. And there wasn't any defined tracks. So now the science is backing us to do so. The other thing is some women, they are like they are ashamed or shy to come and getting checked. So the reason why we did this program is to get women checked, because now we know that there's an opportunity window we call it a 10 years opportunity window, where you're having the estrogen withdrawal, you can prevent dementia, prevent manifestation of all menopause-related disorders such as autoimmune disease. Women get hit harder, the blood-brain barrier get even affected by estrogen, so you have more inflammatory marker. There is also bioenergetic crisis in the brain. There's also a glucose metabolism disorder. Estrogen also play a key player in that. So it's neuroinflammation, it is metabolic disorder, it's neurotransmitter, mood, you name it, all the brain function get a little bit disordered.
Wow. Wow, it's a lot. What about brain fog, Dr. Hanan? So is it different than the menopause brain? Like what? How can we, let's say, diagnose that the patient has brain fog?
So brain fog is the symptom as opposed to the definition of brain menopause. It's physiological, hormonal, and neurobiology. So all of which called like a brain menopause. Brain fog, these are symptoms that some women they have different severity. Majority have like benign course, some have really a new inflection point that take them to a very bad tunnel of diseases such as Alzheimer, autoimmune disease, sleep apnea, significant obesity, cerebrovascular illness, and they go through rapidly into manifestation of different disorder. So it's important to understand what's going on with the women, a brain fog, and we need to address that and treat it, and we need to dissect it. And these are symptoms such as that can mimic sometimes Alzheimer. The woman will feel she has like a slowness in her complex tasks, difficulty with multitasking, unable to concentrate, and the speed of her process is not like the usual before. And the important part, it's mostly fluctuating. It comes and goes and responds to treatment. Sometimes it goes by itself, by lifestyle. A different approach that we do that. As opposed to some women who go into MCI, they have the same symptoms and they go into more progressive, more persistent, as opposed to fluctuation. And this is a huge difference between physiological manifestation called brain fog versus MCI. But women themselves sometimes they cannot distinguish. So that's why sometimes it's important to have a provider that address those issues, because some women go into, as I said, a different inflection point.
So is there like tools that would accurately diagnose, give the diagnosis for a woman? Like, is it like brain fog? Is it maybe psychological symptoms? So do you have the accurate assessment tools that would help in the diagnosis?
Actually, this is very exciting answer. In the past, it was only time will tell us whether these women, when we look into them back retrospectively after 10 years, we figure out a small portion of them go into MCI or Alzheimer's, as opposed to the other recover and they go completely living normal life. So that's all based on clinical tools. But even those clinical neurocognitive tools that like neurologists or cognitive neurology will do, that we used to use a unisex tool, which is traditional one, and women outperform men. So they ace the test, and even the physician, when he or she does this clinical screening, the women outperform men and they look normal because we've been using the different unisex tool. Now, even all research body, NIH, have like a mandate that we should have what we call SBAV. We use sex as a biological variable. So we have to have a different sex-specific neurocognitive tool in order to address and to screen better in women, because we now realize we're missing 3 years of undiagnosed MCI of 2/3 of Alzheimer. So you can imagine if you have 100 million, you're missing 2/3 of those 100 million. for example, are missed. So,
Yeah.
so those SBAB tools address the issues that women is masking. Women have usually what we call verbal masking. They are, by physiology, better than men in verbal memory. So the verbal memory is so strong that they can pass the test, and most of those tests are based on verbal memory. So that's why they outperform men. So we use tools that is different, address the thing that can be subtle, such as executive function, complex task, and others that really miss. And we use a different threshold for even something like a MOCA test. So we focus more on executive function and complex task and visual spatial. Women tend to have more visual spatial, sometimes early navigation issues. As we said, estrogen is a key player in the hippocampus and a prefrontal cortex, where you have the attention function and subcortical attention circuit. In addition to, we have also the visual spatial navigation, in addition, near the hippocampal area. In addition, what we have also, the brain network connectivity, which get disturbed during estrogen withdrawal. So this goes beyond that's a simple, easy test. They need longer tests not to get missed. In addition, what science has told us, now we have biological marker that can tell whether those, we pioneered here in Cleveland Clinic, Abu Dhabi, that can detect the disease at least maybe 10 years in advance. And we're lucky to use precision medicine. And this is where women need to be screened, actually, in addition to radiological markers such as metabolic images, like FDG PET and amyloid images. In addition, there's something now in research which is called estrogen images. We know when we give HRT, this is still research, not standard of care, but there are so many now great opportunities to embark on precision medicine to give women precision medicine, precision diagnosis.
So your approach in the brain health clinic would be different between a woman patient than a man patient.
Absolutely. Women has different brain anatomy. They manifest differently, as I said, and they should be treated differently and diagnosed differently. Even now, radiology now and blood-based biomarker, now the good centers are having different cutoff threshold. We used to do anemia for women. We treat them in different by different threshold. The same thing for biomarker, the same thing for volumetric. So we've been using brain volumetric and comparing women to men, like hippocampus size, the MTA score, what we measure the early sign of Alzheimer, but they have a different brain. So now, since this NIH mandate, starting from research to clinical practice, there's no more now sex-aware cutoff for biology, radiology, and clinical cognitive tool. It's in great center in the world, so they started to be catching up with that. But still, we have many mountains to climb because we need to learn it first and then interpret those cutoff.
As you mentioned, Dr. Hanan, we are pioneers, so we will reach there. So I just wanted as well to ask about the hormone replacement therapy. What do you think about it? Does it really support women brain health? If you can give us some insights about the hormone replacement therapy, please.
Very interesting question. The HRT replacement has many contradictory studies. Some of them say they are helpful, some of them say are not, and they are robust. The one they say it's helpful. So, and some of them say it doesn't have effect. So what we know that it depends on the biological marker, it depends on the genetic, it depends on the comorbidity. So, and the time, the opportunity, we call it therapeutic window. Most of them, when we look retrospect and review all those studies, we found out that it depends on the time you start. So if you miss that 10 therapeutic window between age 40, whatever, some women get early menopause, at age 50, let's say, if she has a menopause, like early menopause, whether it's chemical or surgical, so these are at higher risk by literature. So we have something we call risk calculator and risk stratification. Still, the calculation model is not universal. There's no well-defined tool to do it. But we know from literature, early menopause, women who have hypertension, they get hit harder. Women with ApoE4, for instance, they are at higher risk. So it is, again, it's even in HRT, it's not one size fits all. So women themselves, we have to make a precision medicine based on their risk factor. See, now I can tell you now how much it is a different approach when women have cognitive symptoms. We don't do that in men, right?
So Dr. Hanan, in addition to the cognitive assessment, like what other maybe labs or approaches that you use in menopause women to diagnose the brain issues or Alzheimer's, let's say?
Absolutely. We look into what are the comorbid disease that is more common as you get into menopause. As we explained, the neurobiology play a factor. As we said, the blood-brain barrier become leaky, the autoimmune play a factor when you're estrogen. You are losing your buffer. The estrogen is a buffer for women, not only for cognition, for autoimmune disease. You start to see more Hashimoto at age like 50, you start to see lupus and other autoimmune disease or, polymyalgia rheumatica, all those diseases, arthralgia, symptoms like in all other organs. So I take that into consideration in the review of system as opposed to dementia traditional practice, not focus on women. We don't, even if they don't manifest because they think part of menopause, some women, not really, So we check for inflammatory marker if they have symptoms. As I said, also there's bioenergetic crisis. Their glucose metabolism is affected with estrogen withdrawal, so they start to have more insulin resistance. So we look more focused on insulin resistance, on BMI trajectory, so we can devise tailored approach. So we don't give Aricept if they start having that as a cognitive enhancer. We try to figure out the root cause. And a lot of them, good news, are reversible and treatable. The other things are sleep apnea get higher in men and women, but women hit them harder sometimes, especially the REM sleep. And REM sleep in research, is playing an important role in memory consolidation, especially in women. So even their PSG interpretation, as per research, they have more impact on cognition. Even their EEG, when brain fog, they notice a different alpha power. And with the AI utilization and research has so much robust data and a different signature of EEG in women in MCI versus men. And still not a standard of care, but sometimes we go beyond that. Moreover, we do genetic risk stratification such as ApoE4, well-known genetic risk. Of course, there are so many polygenic risks, but ApoE4 in women, it's part of our risk stratification. And guess what? This ApoE4, if you have a man with ApoE4 and women with the same allele, the same age, the study and science showed us that it affects women harder and has more risk of having Alzheimer for women with ApoE4 than men. Not only that, if you are a woman with Alzheimer, the new data shows you can pass Alzheimer to your kids more than if their dad has Alzheimer. So it's a crisis, it's a family, so we approach it also from family perspective. A lot of my patients, I have their loved one daughters and sons are coming, so it's a disease, it's a family-centric disease.
So genetics then would play a role as well.
As well in risk stratification and tailored therapy.
Yes.
As well, whether it is drug-modifying therapy or whether it is also estrogen replacement. I know that her point is higher in risk, so I can give her HRT, for instance. I would have a risk-benefit ratio goes in favor of giving someone HRT, hormone replacement therapy.
So, what medications would be your first line for a patient, for a woman patient post-menopause with like memory issues or like Alzheimer's? What would be the first line medication that you would prescribe for a patient?
So this is like a very multi-layers question. So for if we have a memory loss, could be like a simple brain fog with some forgetfulness, the approach is different. So the answer, it depends. So if it's a menopause brain fog, which as we said, fluctuating, so we ensure that we tailor to the symptoms. If there are sleep deprivation, there's stress and anxiety can arise if you have a menopause, so we treat the anxiety. So it's basically tailored on symptoms and assessment. That's for brain fog. But if it's an MCI, we know that MCI, it stands for, it's a pathological, it's no longer subjective memory complaint. If we have MCI, mean their daily living of activities start to get affected a little bit, they're still independent. And in this case, we look into drug modifying disease. If their biological blood tests showed that they have amyloid and radiological, now we have amyloid modifying therapy, the novel one, and we've pioneered using now the amyloid PET and in Abu Dhabi, UAE, for amyloid PET image to help us stratify those patients. As I said, and cognitive enhancer. So it's a multi-layered, multifaceted approach, tailored to women, and each woman has a different risk factors and different manifestation. In addition, drug pharmacokinetic and dynamic, when you give the same drug to male versus female, their liver metabolism is different, their tau removal is different. So this is something new research are feeding in, and they have now to figure out women dose versus men dose. It's not still in the standard guideline. And also the side effects of drug, they call it ARIA related from those new drug modifying therapy, they can get more hemorrhage. Some data, for instance. So we have to look back and look into monitor women more carefully when we give her certain drug.
Thank you so much, Dr. Hanan, for this great and informative conversation. What would be your final advice for all women?
Thank you for shedding light on this important topic. I would tell every woman, if you have symptoms, don't ignore it. Take care of your brain like you take care of your breast cancer screening, and get screened for Alzheimer. I know you're at the epicenter of the disease, but good news, we can detect it earlier, we can prevent it, and we can modify it.